In this portion of our treatment protocol for lower limb dysfunctions, we're going to focus on treating the femur and the tibia and releasing the interosseous membrane between the fibula and the tibia. So now, with this portion of the protocol, we're focusing on actually treating each portion of the leg. In treating the femur, we're going to grasp the femur at the proximal edge close to the hip or iliac, once again in a curled fashion, so that we're able to contact in a cylindrical fashion as much of the femur as possible. With the other hand, we're going to contact the distal area closer to the knee. So for those of you who can imagine in your mind a cylindrical movement, I want you to try to grasp the femur as if you were also holding it and intended to rotate it and manipulate it in a cylindrical fashion. Remember that form determines function, so we have a round bone that fits within the acetabulum and is able to do full rotations. So as a result, our femur should also be able to rotate medially or internally or laterally and externally, both anatomically but also within the cranial rhythmic movement. So as you've already noticed, I often encourage any correction to be done within the cranial rhythmic motion of internal rotation and external rotation, because it's like pushing a surfboard out into the ocean as the wave goes out. It follows that you want to do a correction within the body as it's going into that natural motion already. So we're going to hold the femur and we're going to feel for whether or not the proximal area close to the hip or the distal area close to the knee are able to fully externally rotate and internally rotate. So sometimes it's a question of just stopping and listening and say, oh, okay, I can feel it going into external rotation now. Yeah, it's going, okay. Oh, it stopped, now I feel it coming into internal rotation. It's going. Oh, it seems to come a lot into internal rotation. Well, that's somewhat consistent with our anteriorly rotated femur. Or you might feel that it is stuck retroverted in its rotation. Our goal is going to be to balance that, to augment whichever phase it is not moving into fully. So by holding the proximal and distal edges of the femur, we're going to follow its external rotation and internal rotation, and we're going to augment whichever phase it is not doing fully. You're going to repeat this at least 3 to 5 times, or 3 to 5 cranial rhythmic cycles, until you feel that you have induced, because you are going to physically induce in a rolling fashion, in that cylindrical fashion, external rotation and internal rotation. You're going to continue doing this until you feel that there's a fluid rotation in both directions on both ends of the femur. If there's a problem within the head of the acetabulum, you might feel that the femur rotates externally quite easily at the distal edge close to the knee, but not so much at the proximal edge close to the hip. So you might feel that there's a bit of a torsion going on. In that case, you're going to need to induce increased external rotation and internal rotation of the proximal end close to the hip. And then by the time you finish, you should feel that the entire femur is rolling, the whole bone, proximal and distal edge, nicely like a cylinder, internal and external. Similarly, if you feel that the restriction in motion of rotation is closer to the knee, because you have a knee disorder, an angulation disorder within the child's knee, you might find that it's the distal edge that you need to induce more. Either way, our goal is going to be to ensure that the bone is able to roll like a rolling pin equally at either end into external rotation and internal rotation. Next, we're going to do the same thing for the tibia. So we're going to grasp the tibia at its proximal edge, close to the knee. Make sure that we're grasping the tibia and not the fibula. So you're going to want to create a curled motion once again with your hand so that your thumb is all the way medially and you're grasping the proximal end of the tibia. With the other hand, you're going to grasp the distal end also with your index finger and thumb, this portion of your hand. And you're going to feel for, once again, internal rotation and external rotation of the tibia. Now we said that there's already approximately 10 to 15% of natural external rotation of the tibia in a human being. So a normal tibia does not sit perfectly turned straight. It sits slightly turned outward, up to 15% degrees of range of motion. So that being said, when we test for its external rotation, it should be able to externally rotate easily, and it should also be able to internally rotate easily. Often, if there is a problem within the foot, you will find that the distal edge of the tibia does not rotate internally and externally as easily as it does in the proximal edge close to the knee. So you might find that the tibia is doing this, whereby the edge closer to the knee is able to move and rotate, but the distal edge close to the ankle, where there might be a problem within the joints of the foot, are not able to move as fully. Our goal is going to be to improve and increase range of motion of the tibia, both internally, internal rotation, medially, and external rotation or laterally. Our last technique is going to be to treat that interosseous membrane that we discussed. Why? Because in order to be able to release any problem within a leg where there's a foot component, it's important that the fibula, which acts as an external or lateral stabilizer for the foot, not be stuck in a downward position, or not be stuck in an upward position, or not be stuck in a crosswise position, because as we saw, the fibula does tend to move in a figure-8 fashion. This is going to determine the way the foot is going to be able to stand and its weight distribution. So releasing the interosseous membrane is going to be very important in correcting any problem within the foot. It's an inherent part of the structure of the foot. So once again, we're going to grasp that proximal edge of the fibula, grasp the distal edge, and feel for whether it can move towards the head or towards the feet, whether it can move in a transverse fashion, whether it can do that figure-8 motion, and we're going to induce that. So we're going to follow the figure-8 motion that the fibula tends to do, and we're going to induce some natural motion there. Our goal is to feel that the fibula can move somewhat like a seesaw, that the proximal edge can move posteriorly and anteriorly, and also that the distal edge can move posteriorly or anteriorly. but in opposition to each other, like a seesaw. So close your eyes and imagine a seesaw, and imagine the seesaw now also moving in a figure 8 fashion. This is the movement that the fibula should be able to naturally do. So you might need to start by inducing proximal and distal movement towards the head, towards the feet, and then also loosening it anteriorly and posteriorly, and then induce that full figure 8 motion. So what we're doing is we're mobilizing the bone, the fibula itself, but in relation to the tibia. And as a result, what we're doing is we're releasing that important membrane that connects the fibula to the tibia, but we're also releasing any area of the outer malleolus that might be stuck, that might be contributing to an extreme pronation or deviation of the foot. So these are the 3 steps that we're going to do. This is the second portion of the protocol, where we're treating the femur, the tibia, and then the interosseous membrane of the fibula and the fibula itself.